Well, good morning to everyone and welcome to today's Medical Grand Rounds. We will go ahead and get started with a few announcements and introductions. Just some reminders about what we have coming up. So next week, for those of you to whom it matters, is spring break from some of our school systems. So we are keeping in step and taking a break from Grand Rounds next week. So go ahead and enjoy your protected time. And then please join us in 2 weeks, which will be Tuesday, April 4th. And we'll be hearing the talk, De-Prescribing in Older Adults by Dr. Nisha Patel. And now just a few logistics. You might notice that I am here today live in Southern Auditorium at Providence St. Vincent. And thanks for your flexibility as we continue to pivot between virtual and live talks. You can always see where we'll be in the invite to Grand Rounds. And again, you can get CME credit for being with us here in the room, or for watching the talk virtual live, or also by watching a recording of the talk. And that link is available at the same as the invite for today's Grand Rounds. I'll mostly be holding the Q&A to the end of today's talk as time permits, but go ahead and post any comments or any questions that you have. And now to introduce today's speaker, I am delighted to welcome Dr. Karen Adams, who is Professor Emeritus of Obstetrics and Gynecology at OHSU, and also the founding director of OHSU's Menopause and Sexual Medicine program. This program brings together specialists in many fields to provide comprehensive care to women in perimenopause and beyond. Dr. Adams is a North American Menopause Society certified menopause practitioner and serves on the Education Committee of the International Society for the Study of Women's Sexual Health. She'll be starting her new job as Professor of Obstetrics and Gynecology at Stanford University in July of this year, where she will create and lead the Stanford program in menopause and healthy aging. Dr. Adams is well regarded as a master clinician, as well as a leader and educator. We are so delighted for her generosity in agreeing to come and teach us once again today. Thank you, Dr. Adams.
Thanks so much, Dr. Laura. You guys, thank you for inviting me. I just can't see all the menopausal patients who need to be seen, right? Neither can you. All of us see these patients, and the state of care of menopausal patients, can I say sucks at Grand Rounds, is not good. It's not good because most of us came of age in our medical careers during the Women's Health Initiative time. And so training wasn't good. Practitioners kind of fell out of comfort in taking care of these patients. So I love, love, love talking to really anyone who will listen to me. I'll talk to one fellow. If you'll put me in front of one fellow, I'll talk to them about this. So thank you so much for this opportunity. I do hope that this is clinically relevant for you, and please do ask your questions. I do have a tendency to get a little bit on a roll, and but please, you know, wave and stop me if you need clarification or if you need more information. Because so much of this talk is about heat, we're going to throw some cool pictures in as well. So this is a cool picture. I do want to say that I try very hard to say menopausal people because the terms woman and female aren't always how people describe themselves. Sometimes there are people who have ovaries. All of them are people who have cessation of ovarian function. I use the term woman and female with that understanding, also knowing that that's how the patients or the subjects in a lot of the research are described. I will try to tell you when I'm talking about off-label uses of drugs. I don't have any conflicts. I do want to acknowledge the North American Menopause Society and ISWISH, the International Society for the Study of Women's Sexual Health, both great, great, great resources. And Jan Schifrin, who is the director of the Harvard Menopause Program, who provided some of these slides very generously. And then my other disclosure is that I'll be at Stanford in July and hopefully providing some education for providers and patients all up and down the West Coast. So planning to really collaborate a lot with the OHSU Center for Women's Health. So my learning objectives are that when you finish this talk today, you will know the important guidelines regarding hormone therapy. We used to call it HRT. We now call it HT, hormone therapy, use in various clinical settings. So when that menopausal patient comes to you, when that patient with premature ovarian insufficiency comes to you, when that patient with BRCA who's getting ready to have a risk-reducing oophorectomy or GSM, genitourinary syndrome of menopause, you'll know what to do. And that you'll understand the importance of individualization of this. This is never, never, never one size fits all. And I think I like this slide because it's really important that we have a little bit of a perspective about what the Women's Health Initiative was all about. What was it designed to do? It is the best evidence that we have and that we will ever have concerning the risks of hormone therapy. That's what it was designed to do. And if anybody is holding their breath waiting for that study to be repeated, give it up. It will never be repeated. It was the largest trial ever, and they're continuing to follow those women. So I'm going to give you some updates about the data. But it was never designed to address the benefits. And in fact, quality of life was not even included in the global index, which is so significant. Because yes, we're talking about long-term health risks, but we're also talking about symptom management and quality of life. And those two things don't necessarily have to be either or. So always individualize. I'm going to beat this to death through this whole talk because the risks differ depending on the dose, depending on the duration, depending on the route of administration, et cetera, et cetera. I don't have to read all this for you. But it is important that you think about this person who's sitting in front of you and what are their individual risks and benefits. And this is not one of those people who you're going to say, okay, come back in 5 years when it's time for your PAP. So you want to see them once a year. You want to make sure you reevaluate at least once a year. Make sure you see if there's any new risk factors, any changes in their health history, etc. So it's never cramming a square peg into a round hole. And so I want to talk a little bit about symptoms. And this is a slide that I update as the data comes out. Unequivocally, hormone therapy is going to be beneficial for vasomotor symptoms, hot flushes and night sweats, and vaginal dryness. I tell my patients the vagina loves estrogen, and it gets very unhappy when estrogen declines. And so we'll talk about that. Beneficial for most people is going to be improvement in sleep, improvement in mood, and joint pain. Interestingly, I just moved joint pain from the conflicting inadequate data to beneficial for most because there's been enough data now to show that it really does. And I bet those of you who take care of these patients have heard this. You're like, yeah, my joint pain's better. So I never promise those things, but typically things will get better. Sleep will get better, mood will get better, and there's great data about that. Estrogen works for mood disorders, particularly in the perimenopause. So please invite me back. I will talk about mood and menopause because that's a whole nother talk. Oh, and also I should shout out, there's going to be a program called ECHO, which you may or may not be familiar with. ECHO is a way to train providers without them having to come to a thing like this. It's a 12-week curriculum that you can sign up for. It was actually set up initially to be related to hepatitis C management and substance abuse management, things that can be a 6 or 8 month wait to get into a tertiary care center, and trying to provide education for providers out in the community. And we're going to be doing one through OHSU on menopause. There's going to be 12 weeks, and you're going to get more menopause than you possibly ever thought you would need. But boy, oh boy, you will be so smart. So stay tuned for that, because we are going to be providing that. And we'll be talking about in that curriculum about poor sleep, about adverse mood, why estrogen really works for those things. conflicting and inadequate data about the other things. Sexual function is really challenging, and there's really no evidence that estrogen improves sexual function apart from its ability to treat pain. So it's totally sane and normal not to want to do something that hurts. And so if they're having dyspareunia, the estrogen will help with that, but it's not going to get their 30-year-old libido back, I wish. Urinary incontinence, systemic makes it worse, local makes it better. Brain fog, changes in body composition, that sarcopenia, the marbling of the muscle with fat that happens in menopause. Some evidence that might improve, but some it doesn't. It doesn't show any benefit. And then skin dryness and wrinkling. But 80% of people have hot flushes and night sweats, so that's what's going to be driving people to come to your office, and you can fix that in a couple of weeks. Okay, I want you to be aware of this. The North American Menopause Society has incredible resources on its website, and it's www.menopause.org, and most of this is available whether you're a member or not, but I encourage you to be a member because then you get practice pearls and all kinds of things. But they put together this 2022 hormone therapy position statement, and the document is about 60, 70 pages, but there's a nice executive summary at the beginning that's very useful. And so the way we're going to think about this today is I'm going to give you these cases that we talked about, and then I'm going to refer to the position statement so that you'll know kind of what the party line is about this. And I will say that, you know, that this is a group of people who tend to be pretty pro hormone therapy. However, they're very clear about the risks of it as well. So I think it's a pretty good document to use to guide your practice. Okay, so here's something cool. All right, so let's start with Doris. So Doris is a 54-year-old special ed teacher. Her last period was 2 years ago, so that makes her fully menopausal. The definition of menopause is no period for a year. So she's fully postmenopausal. She's got hot flushes, night sweats, disturbed sleep, fatigue, irritability, vaginal dryness, and dyspareunia. So she's kind of got the whole gamut of symptoms. She's tried some behavioral things, some over-the-counter things, black cohosh, soy, yoga, meditation. Nothing much is really helping. Her medical history is that she's healthy. She's got hypothyroidism. She's got fibrocystic breasts. And her meds are only levothyroxine, and she takes a calcium supplement with vitamin D. And as far as her family history goes, her mom had osteoporosis, her aunt has breast cancer, and her brother has heart disease. So she comes and says, you know, I really want to feel better. So we're going to talk today about what are the principal indications for systemic hormone therapy and or low-dose vaginal estrogen therapy. So those are two different things, and when are we going to use each of those? What are the hormone therapy contraindications, risks, and benefits, and how best do we optimize and individualize? Okay, so this I think a lot of us don't realize. We don't realize that hormone therapy is FDA approved for 4 different things. One is hot flushes and night sweats. One is treatment of genitourinary syndrome of menopause. One is very specifically for treatment of premature ovarian insufficiency. So premature menopause, whether that be natural, medical, or surgical. And then also prevention of bone loss and fracture in high-risk women. So not treatment of osteoporosis, although it does work for that. It is FDA approved to prevent bone loss and fracture in high-risk women. So those are the 4 areas that you are going to be very well within the FDA guidelines if you use it. All right, let's talk a little bit about vasomotor symptoms. This is one of the most important slides in this talk, and the reason is, look at this, in the 3rd line, early to late perimenopause, in people in their late 40s, up to 80% of those people are hot flushing, and they haven't even stopped their periods yet. So I see a lot of patients coming to me going, my provider told me I'm still having a period now and then, and so this can't really be about menopause. No, the perimenopause is the most symptomatic time for mood, for hot flushes, for everything except vaginal dryness. Vaginal dryness is progressive and it gets worse as people age. But perimenopause in general is the time that people are going to be the most uncomfortable, and up to 80% of people are hot flushing. So that is really important to have a high index of suspicion, even in your patient who's less than 45. Up to 45% of those folks might be hot flushing. So kind of shift your mindset about that, your mental model, to think that this really could be hormonal. If you do nothing, if they say, you know what, I really don't want to take that stuff, I just want to tough it out, how long is this going to last? 30 to 50% of them are going to get better within about 4 to 5 years. 80 to 90%, 85 to 90%, it's going to take 7 to 10 years. We used to tell people it takes about 4. And then there was an article in JAMA that came out about 5 years ago saying, no, average is 7 to 10. And we were like, yeah, no kidding, because that's what we've been seeing. And then there's this group of people called super flushers. Oh my gosh. And they will have symptoms many years after menopause. So that person who's 65 and comes to you and says, I've been doing this so long, I'm sick of it. That's real. That's real. All right, so this is what's going to happen if you treat your hot flushes. So let me see if I have a pointer here. So here's placebo. This group right here is estrogen alone. This data is conjugated equine estrogen, right? So that's what we used to study mostly before we started using estradiol. So these are different doses of unopposed estrogen in people with a hysterectomy. And you can see that in the first couple of cycles, placebo is going to be effective. So placebo works at the beginning, but then they still settle out at around 5 to 7 hot flushes per day per cycle. So down here on the x-axis, each one of these numbers represents a month because these are cycles. And so in the first cycle, you're still having pretty significant amounts of hot flushes, but still some improvement even after just 1 cycle. But man, after 3 cycles, you really have some improvement. Not at the lower doses, but with the 0.625, which is kind of the standard what's in Premarin, Prempro. And then this is estrogen combined with medroxyprogesterone acetate, MPA, and at different doses. And look at this. So you add the progestin and you get better control of the hot flushes. So that's important to know that some benefit will come from progestin. So what does the North American Menopause Society say about that? They say the hormone therapy is the gold standard for relief of vasomotor symptoms, and it's either estrogen alone, estrogen therapy, estrogen plus progestin, and progestin alone is the best alternative to estrogen, which we don't tend to think about, right? We tend to think more about like SSRIs or gabapentin. There aren't a lot of contraindications to progestin use. Even people who have had a clot can do progestin. So remember that you can do a little oral bioidentical progestin, and I'll talk to you about that, about what's bioidentical. You can try that. You can even try something like Depo-Provera. Anything that's going to give you systemic doses of progestin is a good alternative for people who can't take estrogen. You want to use the lowest dose that's going to give relief and periodically reevaluate. SSRIs, SNRIs are a good option as well, a good alternative. But remember, with those drugs, a lot of times orgasm kind of packs its bags and moves away and goes, far away. So people say, man, my sexual functioning really took a hit with the SSRIs. Gabapentin is 3rd line, but you might choose that if they're already dealing with low libido or anorgasmia. And here's a little practice pearl about how do you dose gabapentin. for vasomotor symptoms. Some people will need like 200 3 times a day, but if you start them on that, they're going to be dizzy and kind of wobbly and not feeling great. So you have to really step it up slowly. And so the way I do it is I start with just 100 milligrams at night and have them do that for a week. And then I add the 100 in the morning, have them do that for a week, have them then add one in the middle of the day, and then just keep bumping it up like this until they reach a point where their hot flushes are better. And for most people, it's going to be somewhere around in here. But you can keep pushing it all the way up to 300 TID. So this is another option that you can try for somebody who can't take estrogen. Okay, but now we're going to dive in and we're going to talk about hormone therapy and all the things to know about it. So the Women's Health Initiative really surprised those of us who were taking care of these patients because we had so much observational data that said that estrogen was beneficial to the heart. And the PEPI trial, which is the postmenopausal estrogen and progesterone intervention, and several others talked about beneficial effects on lipid panels and various kind of improvement here in heart disease outcomes. So it was really surprising to see that in the Women's Health Initiative, coronary heart disease rates went up by 29% and stroke rates went up by 41%. And that really wasn't consistent with what we had seen in observational trials. And those numbers sound really scary. And breast cancer went up by 26%. So those are the numbers, these 29%, 41%, and 26% that hit Good Morning America and hit Today and hit the New York Times and made the phones ring off of all of our walls in the clinic that day because people were like, what? And here, I think, is a much better way to think about that data. Now, if you look here, here's those numbers: 29% heart attacks, 41% strokes, 26% breast cancer. But how does that translate to absolute risk per 10,000 women per year? 8 extra cases of breast cancer per year, per 10,000 women, 8 extra strokes per 10,000 women per year. When you talk about that with your patients, it helps them understand that that risk is really per 10,000. And they say, wow, 10,000 people, that's like half a football stadium. 8 extra cases, that's not likely to be me. So that is a much, I think, more effective way to help your patient understand the risks that we're talking about. And when you compare it to lifestyle risks, it's off the chart. Breast cancer risk is greater with a sedentary lifestyle, alcohol intake, or obesity than it is with estrogen. So people have so much control over these risks. And it's always amazing to me how people are afraid of estrogen when they're so willing to smoke cigarettes or not exercise or walk around with a BMI of 35. So helping people understand the risks and benefits is really something that you can do to benefit your patients. So try to remember these numbers. This is what I think really helps people understand. 7 cases per 10,000 extra heart attacks, 8 extra strokes per 10,000, 8 extra breast cancer cases, and 18 venous thromboembolic events. But 6 fewer colorectal cancer cases and 5 fewer hip fractures. And that's in the combined estrogen and progesterone group. When you look at the estrogen alone group, they actually had fewer heart attacks. They actually had fewer rates of breast cancer. So some people look at this data and they go, can I have a hysterectomy, please, so that I don't have to take the progesterone? Because that's the only reason we add the progestin, is to protect the uterus from the endometrial hyperplasia risk. And so people who have a hysterectomy even have a better risk profile. So I think it's important to kind of be able to put these numbers in perspective. The other thing is Women's Health Initiative enrolled women between the ages of 50 and 79. The average age of the women in that study was 64. And people respond differently to hormones depending on their age. And so look at these folks in the 50 to 59 group, very much different profile from those people who got started on hormones in their 70s. So I don't think anybody, as much as I love estrogen, and I'm 64 and they will get mine when they pry it from my dead cold hands, I wouldn't start me on estrogen now, and I wouldn't start someone who's in their 70s on estrogen now. But we are using that data to inform our care of people who are 48, 50, 52, and they have a different risk profile. So that's also a really, really important thing to take from this talk. And the cool thing is they keep publishing more data about it. And so Joanne Manson is the primary person who writes these articles, and she published in JAMA in 2017 the data. Now here we're 18 plus years later. And these folks, the people who had the combined estrogen and progestin, were on it for an average of 5.6 years, and the estrogen alone 7 years. They followed these folks, and there has been no increase in overall cancer deaths, including deaths from breast cancer, no increase in deaths from cardiovascular disease, and a statistically significant reduction of all-cause mortality when it started in that first decade after menopause, 50 to 59. So this, I think, is also very reassuring to us that when somebody comes to you at age 49, 50, 51 and is miserable, and like our friend Doris here, who's quite low risk and doesn't have any specific risk factors, that you can feel very comfortable treating her with estrogen. So here's something cold. All right, so what are the risks that you want to look at? Well, you want to look at their age, of course. So somebody who's between 50 to 59 is going to have a different risk profile than somebody over 60. How many years has it been since menopause started? And that's what we know from the ELITE trial. They put the people in the same group, 50 to 59, so under age 60, or less than 10 years out from menopause. So if somebody's menopause wasn't until 55, 56, they still have a 10-year window that they're going to get that benefit. So age, years since menopause, lipid status in terms of her cardiovascular risk. Does she have metabolic syndrome? Does she have underlying coronary heart disease risk? So those are the things you're going to be really looking at in terms of that individual patient's risks. Okay, so who are the people that you really don't want to give estrogen to? In terms of cardiovascular disease, if they have active heart disease, if they have had an event, if they've had a stroke, if they've had an MI, if they have active cardiovascular disease. Also, if they've had a clot, if they've had a DVT, if they've had a PE, those are the folks you're probably going to try just progesterone alone on and not give them estrogen. Someone who actively has breast cancer, not a family history of breast cancer, we'll talk about that, but someone who has the diagnosis and is being treated for breast cancer, that in general is an estrogen dependent type of cancer. And even with the ER/PR receptor status, you're still going to want to avoid breast cancer, estrogen in breast cancer patients. Endometrial cancer is in the list of contraindications. However, most of us in real practice say an early stage 1 that was treated with hysterectomy and negative lymph nodes, you know, that's okay if you've had a conversation with the patient and with her gynecologist. But always you want to collaborate in your care of those patients and make sure that you've communicated with the oncologist. And then, of course, any undiagnosed vaginal bleeding. Relative contraindications would be if they have risk factors for these absolute contraindications. But again, that's always going to be a risk-benefit balance discussion. And, as a gynecologist, I'm going to want to loop in you guys. Hopefully, as primary care docs, you're going to want to loop in us, and we'll figure out together what's going to make the most sense for that patient. So there's a bunch of different ways that you can dose this. Combination hormone therapy comes in a patch or a pill. So there's some patches that have both. And then the first two are patches, the bottom three are oral. And then estrogen alone comes in a patch, comes in a gel or a spray, mist, and some oral. So we'll talk about how do you pick which one. This is another really important take-home message, transdermal. You really want to start with that rather than oral. Why? Because you swallow an estrogen pill, it goes into the liver responds by making clotting factors, and we can take that risk down to baseline, down to zero by doing something other than a pill. So you do a skin patch, you do gel on your arm, you do a ring in the vagina, you do something other than oral if you can, or to start with. The benefits of that are that you have a lot of different forms that you can offer. It's very convenient that most of the patches that we use are once or twice a week. You have them put it right on their abdomen, so mid-torso, not directly on the breast, not directly on the arm. It will not absorb from those areas. So mid-body, stick it kind of anywhere mid-body and change it twice a week. And I tell people move it around a little bit because sometimes people get a little rashy under the patch. There's also a ring that delivers systemic doses, and you just put it in and keep it there for 3 months in the vagina. Some people like that. It gives you a little more consistent blood level. You have a whole bunch of different dosages that you can use. An estradiol patch comes in 5 doses. It's also bioidentical, which people like. So we'll talk about what that means. And it doesn't go into the liver, so there's no first pass effect, and so it doesn't impact lipids or clotting factors. And as near as we can tell, there's no increased clotting risk, and potentially it has a decreased cardiovascular effect as well. Drawbacks are that it can be a little bit expensive, more expensive. That's getting better. And there's not a whole lot that has both estrogen and progestin in it. So depending on what you choose, they may be doing a patch and a progesterone pill or an IUD. I don't really like the combination patches simply because I found that people have a ton of breakthrough bleeding with them. And it's such a pain, and they're really bothered by that. So I like to do a patch and either a progesterone pill or an IUD. And then some people get irritated on the skin, and they just really. I have one patient who her whole face broke out in hives, and it took us about 6 weeks to get the hives to clear up. So some people get skin reactions to the adhesive. So does the progestin actually matter? It's interesting, isn't it, that those people who had estrogen and progesterone together had the increased risk of breast cancer, and the people who didn't have progestin had improvement, fewer cases of breast cancer. So what's that about? We don't really know. But that study was done with medroxyprogesterone acetate, which is a chemical form of progestin. Most of us now use prometrium, which is micronized oral. And again, it's bioidentical, meaning that your body recognizes it. It's the same hormone that was circulating in your bloodstream during your reproductive years. And you can see all the benefits of the micronized oral. And there's this new combination oral product available. It's called Bijuva, and it's got oral estradiol and oral prometrium in it. Again, it's not going to be your first choice, but somebody who for whatever reason can't do the transdermal, you've got that option as well. And then some people don't like the progestin. They kind of feel crummy on it or a little brain foggy. I like to give it to people at night, prometrium at night, because one of the side effects is a little bit of drowsiness, and it helps people sleep. have a patient who's in an academic office at one of the universities in Oregon, and she called the office one morning and she said, I forgot to take my Prometrium last night. I took it this morning and I'm having to cancel all my meetings because I'm like falling asleep at my desk. Is that the Prometrium? We're like, yeah, it's a Prometrium. So if sleep is an issue, have people take it at night and that can help. But some people feel uncomfortable on progestin, and so you can do a 3-month, 10-day, i.e. withdrawal bleed, sort of a cyclic thing where you do the patch, and then for 10 days you do 200 of Prometrium, and they might bleed, they might not. Or you could do a levonorgestrel containing IUD, the Mirena IUD. That's off-label, that's not FDA approved for opposition, but because of the mechanism of effect, it works. So a lot of us use that. So bioidentical is something patients come in and they ask for. It means that your body recognizes it. It's not conjugated equine estrogen, which your body never saw. Conjugated equine estrogen is Premarin, and it means pregnant mare's urine. It comes from pregnant mare's urine. They have horse stables where they collect the urine, and that's how they make Premarin. So estradiol, estrone, estriol, testosterone, and progesterone are all bioidentical. So when your patient says, do you prescribe bioidenticals? You can say, yes, I do. Now, it does not mean compounded. So it doesn't mean that somebody's, concocting something in the back room of a pharmacy. It's FDA approved, and it's bioidentical, because compounded is not something we recommend. We don't recommend that. The majority of them, you can't be sure from batch to batch how much people are getting. There's no FDA package insert in those, and we just in general don't think that those are safe. Transdermal topical progesterone cream does not give you endometrial protection, and so although it can help with hot flushes, you run the risk of endometrial hyperplasia. So yeah, we're not big fans of compounding. So these are all the FDA approved formulations of bioidentical hormone therapy. Most of the time we use estradiol, and it's oral, tablet, a skin patch, gel or cream. They're metered pumps that they put one pump in the palm of their hand. It's called Divigel, and you go shoulder to wrist and you just smooth it that way. And that's a transdermal method if they don't like the adhesive on the patch. And then there's a vaginal ring, femring, which delivers systemic doses, as opposed to estring, which is local. So be sure if you're writing a ring, most people don't use this very much. It's very expensive, and people, in general, I find the usefulness of it is pretty limited. But if you think about a ring, just know that femring is systemic, estring is local. And then oral Prometrium is bioidentical. There's something cool. Whew, that's a lot. Okay, so Maria is a 35-year-old accountant. She's had no period for 13 months. She's 35, no period for 13 months. So you're going to work her up. HCG is negative. Her thyroid, her prolactin are normal. Her FSH is 59. Her estradiol is 12. And she doesn't bleed if you give her a week of progesterone. What's her diagnosis? Premature ovarian insufficiency, absolutely. We used to call it premature ovarian failure. We don't call it that anymore. It's premature ovarian insufficiency. The definition of that is no period with a negative workup before age 40. So under age 40, it's premature ovarian insufficiency. Anything from 45 and on is considered normal menopause, and that 40 to 45 range would not be premature ovarian insufficiency, but could be potentially early stage menopause. In this patient, the benefits of hormone therapy outweigh all the risks for all of these things, and she is going to have a higher all-cause mortality because of being premature ovarian insufficiency, and you can mitigate that to a certain extent by putting her on hormones. Now, how much is she going to need? She's going to need a lot, because you want to push her up to a reproductive age woman's level, so different from a postmenopausal person. So you want to give her hormone therapy at least until the average age of menopause, which is about 50, 51. These people might ovulate now and then. Newsflash, newsflash. Occasionally, these people will ovulate. And so they need contraception as well if they would not consider a pregnancy to be a positive thing. Some people would say, gosh, if I got pregnant, that'd be amazing. That'd be great, which is fine. But be sure to know that that ovary might wake up now and then and ovulate. And so you want to talk about contraception with them. So a 0.1 patch, which is the highest dose patch, plus an IUD would be perfection for this patient because it's going to manage her symptoms and give her contraception. Or you could give her oral contraceptives. That would be fine with the usual contraindications. But that's not our choice. We prefer the bioidentical estradiol because oral contraceptives have ethinyl estradiol in them, which we think might be a little bit less effective for bone protection. So but you know, like I have one patient, she's like 37, premature ovarian insufficiency, and she's virginal. She's never had sex, and she does not want an IUD. And so I've got her on birth control pills, and that's fine. That's fine. But that wouldn't be my first choice. I would try to do the patch and the IUD. So what is this whole lowest effective dose thing? So typically, just a postmenopausal person, I'm going to start with the 0.05 milligram patch, which is estradiol patch, which is pretty standard for a 50-year-old, again, on the abdomen, like we talked about, and prometrium 100 milligrams at night, or a levonorgestrel IUD. And what that's going to get you to is a serum estradiol level of around 30 picograms per ml, which is going to treat her hot flushes. Now, you don't need to check the labs. You can just see whether or not she's responding. But in your own mind, 30 is going to get you to hot flush management. If you're really worried about her bones, if she's really frail and fair complected and her mom had a fracture and all that, you might want to push her up to about 40 to 80. That's, you know, going to give her bone health and cardioprotection. But again, a lot of people will get to that with 0.05. Premature ovarian insufficiency, your target is 100. So you want to check levels on that person and push her up to 100. So you're going to maybe need to try 2 patches. So estradiol is good in this range, in this situation, because you can get a serum estradiol level, whereas you cannot get an ethinyl estradiol level, which is birth control pills, or conjugated equine estrogen level, which is Premarin. So that's another reason why estradiol is a good choice. How often are you going to get estradiol levels? Not routinely. You're mostly going to just use it, you know, like manage her based on her symptoms. But if you are really worried about her bones, or if she says, I really, really, really want every single ounce of benefit I can possibly get from estrogen, then you might check a level once a year and shoot for 40 to 80, and then she'll get bone and heart health there. The other time I will do it is if I've got somebody on something that I think ought to be working and it's not working, and they're hot flushing and stuff, and I'm like, gosh, you're on a normal dose. That's weird, because some people just don't absorb it very well from the patch. And so so if she's not responding, then maybe I'll get a level. Progesterone levels tell me nothing, and I hate it when people come in from the naturopath and they've got $700 worth of labs that they want me to interpret, and none of them mean anything to me except the estradiol level. So that's a shame, but don't draw progestin. It's not going to tell you anything. If you're going to draw it the day before they change their patch, and stop all biotin containing vitamins 48 hours ahead of time, because it's going to interfere with the serum assay, and you're just going to order a serum estradiol. How long do you keep these people on it? Well, you know, you're going to see them every year, kind of reevaluate the risk-benefit balance. Obviously, absolute risks that increase with age are heart disease, stroke, venous thromboembolic events, PEs, breast cancer. But there's no recommendation to automatically stop this at any time. I'm not going to start a 65-year-old on hormones if she went through menopause at 50, because the data does not support that. But if she's been on it since she was 50 and she loves it and she doesn't want to go off of it, you can have that conversation with her depending on what her overall risk factors are. So there's no recommendation at a certain age to stop. Okay, here's something cool. All right, here's Barbara. She's a 40-year-old fitness coach and she's BRCA1 positive. And she's going to have her risk-reducing BSO because she's 40, she's had her kids, and she's getting ready to have her ovaries out. This woman is going to start hot flushing in the recovery room because as soon as her ovaries come out, she's going to feel it. So she's going to wake up out of the anesthesia hot flushing. So how many of you would give her hormones? Please raise your hand. Yes, you would. You would, you would, you would. So here's the NAMS position statement. Hormone therapy does not further increase the risk of breast cancer in women with high risk because of a family history of breast cancer or after BSO for BRCA1 or 2. Now, this is observational evidence, but we don't think this increases their risk at all. And she's essentially premature ovarian insufficiency almost, right? I mean, some people have their ovaries out at 35. So she's in that age, 35 to 40-ish, where she's going to have all-cause mortality increase because of her ovaries gone. So you want to give this woman estrogen. So it doesn't matter. It doesn't matter. You know, a lot of these folks have both. They have mastectomies and they have their ovaries out, but that doesn't change their risk. So the way the position statement is written is that BRCA positive women who've undergone risk-reducing salpingo-oophorectomy can be given hormone therapy, at least until the age of menopause. So they don't recommend it, and a lot of us argued about that because we thought they should recommend it, but they thought, well, this is where you really have to have some risk-benefit discussion. And some of these women, they don't want to be in the same room with estrogen. It scares them, you know, but these people should have been on birth control pills until they had their oophorectomy, because that decreases their risk of ovarian cancer. And so you know, you may have already had that discussion with them, but talking about the benefit for heart and bone and symptom management is important in those folks. This is very reassuring to them too. The risk of breast cancer with hormone therapy is more with a sedentary lifestyle, alcohol intake, or obesity than it is with estrogen. And so we really don't think there's any safe alcohol intake, but for women in general, we recommend no more than 7 drinks a week. So one glass of wine or one cocktail, no more than that. Anything more than that really does increase their risk, and ideally none is best. Okay, here's something very cool that you guys will be hearing about as of May. There's some new drugs that are coming out that are for hot flushing that are not estrogen. They hit the candy neurons. I love that name. I wish I was responsible for the drug development, the candy neurons, and kisspeptin and neurokinin B and dynorphin. The candy neurons here at the bottom are co-localized with almost more than 95% of the estrogen receptors, progestin receptors, androgen receptors in the arcuate nucleus in the brain. So fezolinetant is expected to come out in May of this year. It was set to come out in February. The FDA pushed it back. They asked for more time to review, but it works by blocking neurokinin B in the brain, in the candy neuron. And I have to write this mechanism out because I could never come up with it myself. It modulates neuronal activity in the thermoregulatory center of the brain to reduce the frequency and severity of moderate to severe vasomotor symptoms. Now, it's not going to help for bones. It's not going to help heart health. The main side effect is headache, which seems to be dose dependent, but minor, not terrible. It also is contraindicated in people with any kind of liver abnormalities. This is probably going to be used for people who cannot take estrogen. So estrogen is probably still going to be your go-to, but for people who cannot take estrogen, this is going to be a great alternative. Those poor breast cancer patients just struggle with their hot flushes. And so they are going to do some upcoming trials of this drug in patients with breast cancer. So that's coming, and you can anticipate that. Finally, my last little bit, I'm going to talk about genitourinary syndrome of menopause. So genitourinary syndrome of menopause is a later symptom, usually. Some people start having pain in their late 40s, but it's progressive, and hot flushes, if they do nothing, most of them eventually will go away. The vagina never gets more happy. It just gets more unhappy. So it's better to treat this early and aggressively if they've got dyspareunia. And about 50% of our patients will have it. About 50% won't, which I think is really interesting. I have a patient, she's 80 years old. She's having sex with 2 different men. No pain. No pain. I'm just like, you're my hero. I can't believe it. And she said, why not? So that could be your patient, but 50% do have GSM, and of those 50%, only 6 to 7% are treated. And that is such a tragedy because it's 100% treatable. So please ask your patients about this and treat it. And again, this is just a visual that says it gets worse as people get older, and it gets up to about 50% when people are 3 years post-menopause. Oops. So what are the guidelines? The guidelines are you start with over-the-counter lubricants and moisturizers. Lubricants are to be used at the time of sex. Coconut oil is my favorite. It's cheap, smells great. It's naturally antifungal, so it will tend to keep down yeast infections, and it absorbs slowly, so it stays where you put it, and it's very slippery. Silicone is my second favorite. A lot of people don't like the way it feels. It feels kind of chemically and kind of yucky, but it sticks around. Water-based lubricants absorb very quickly and should really only be used if you're using a silicone sex toy or a condom. So lubricants with sexual activity, moisturizers for weekly maintenance, and then if nothing's better after 3 months, go to pharmacologic options. These are vaginal moisturizers. Vaginal moisturizers were designed for people with breast cancer who didn't want to take estrogen. And what they are is they're hyaluronic acid polymers that adhere to the vaginal epithelium, and they absorb about 1,000 times their weight in water. And they keep that adherent to the vaginal epithelium until it's sloughed off. So 3 times a week, your patient gets out of the shower, she moisturizes her face, she moisturizes her body, she moisturizes her vagina. And so these are just plungers, and you just insert the gel up inside. Hyalogine is available online. Juvagyne is available online. It's like $30 for a month's worth. It's not too expensive. Replens makes both moisturizers and lubricants. The lubricant is terrible. The moisturizer is great. So when you send your patient to Rite Aid, be sure that they're getting the proper one. And then low-dose vaginal estrogen. There's really not any contraindications to this. Even people with breast cancer can use this. You can do a cream, you can do a ring in the vagina, you can do a tablet, or the vaginal insert. And I'm giving you this table mostly for your reference. You can look at this when you're in the clinic because it says how you dose it and what to tell your patients about the advantages and disadvantages. The cream, most people are putting it in the plunger and squirting it up inside the vagina, and that's not usually where the pain's coming from. I usually tell people just put a blob on your fingertip, like the amount of toothpaste that you would put on a toothbrush, and rub it into the opening of the vagina and rub it up to the clitoris and the opening, the urethra. That's going to get you more bang for the buck, and the tube is going to last longer. But the estradiol tablet is something that some people like because it's less messy. The insert, the ring again is systemic doses versus local doses. If they're worried about their partner absorbing it, they really don't. Men are covered with skin. Women's vaginas are like mucosa, like the inside of your mouth. So they're going to absorb a lot more than a male partner would. So they can have sex after using it and it won't be a problem. So here, this is something I want you to be aware of. This is serum levels, right? So baseline with no treatment, their serum level is about 4 to 5. Now remember, 30 is what treats hot flushes. 100 is reproductive years. So this is a menopausal range of serum estradiol. So baseline or placebo is going to give you this. And these are all the different local forms. They're all basically hanging out in the postmenopausal range. So your breast cancer patient isn't going to have an increase in recurrence risk unless she decides she's going to bathe in the cream. You don't want people to just, just bathe in the cream. The ring, here's the local one. These are the 2 doses that provide systemic effects. So this is treating vasomotor symptoms as well as vulvovaginal atrophy. So again, just so for your knowledge of the safety of this. So it is safe. And when we measure serum levels, it's all within menopausal levels. The cream can be a little bit more if people use a lot of it. But also in checking endometrial stripes, we're not seeing thickening. We now have 7-year follow-up for this. And so this is really important. Talk to the breast oncologists. You got to practice in this town, and you don't want people mad at you for putting your patient on estrogen if you haven't talked to them about it. But usually I speak to the breast cancer docs, and they're pretty aware. All local estrogens have scary package labeling, so warn your patient. And it's going to say endometrial cancer, cardiovascular disorders, breast cancer, probable dementia. We have gone to the FDA so many times asking for them to take this labeling off, and they will not do it. It's a class black box warning on all estrogen products, so just be aware of that. The last little take-home point I want to give you is the North American Menopause Society has this very cool thing on their website called Meno Notes, and they are little handouts that you can print and keep in a file in your clinic and give them to patients. And they cover all of these different topics, and they're just very cool. NAMS is very much about making your life easier, and so I really encourage you to go to that website and have a look and see what resources are there for you. All right, you guys have held on, which has been great. Here's the wrap up. Hormone therapy is currently the most effective treatment for vasomotor symptoms. There are many estrogen and combined products available in varying doses. Transdermal estrogen, micronized progestin is going to be your preferred approach. You're going to use the lowest effective dose, reevaluate periodically. Patients less than 10 years from menopause are the best candidates or under age 60. Women without a uterus have a little bit more of a favorable risk profile in terms of the risks long term. Breast cancer risk is low overall, 8 extra cases per 10,000 women, and it's lowest in the first 5 to 7 years, so during that time when people are symptomatic. Local estradiol can always be used to treat GSM, but confirm with the med-oncs. This is something cool, and we are done. We are done. Yay, you guys. And this is, I refer you to my TED Talk. I gave a TED Talk a couple years ago. 2 things that predict a great quality of life for all adults: good sleep, good sex. Menopausal women don't have either of those. And so, so you can do a lot of good to for your patients if you educate yourself about that too. Thank you so much for having me. I'd love to take any questions if you have them.
Great. Many, many thanks, Dr. Adams, and a comment here online. Excellent review and practical advice. And I do have to say, you've already answered several of the questions online throughout your talk, but I'll pose a couple as we wait for the room here. I think you did confirm, there is a question here, if a patient has an IUD with progesterone in it, could estrogen hormone therapy alone be used? And
yes.
That does sound like a...
Yes, and we think the risk profile might be similar to unopposed estrogen because the IUD progestin doesn't circulate systemically. It's really local. So we think it's really the sweet spot. Most of my gynecology partners have a patch and an IUD. That's what we do. Mm-hmm, mm-hmm.
Thanks so much, Dr. Adams. I was wondering about pellets. My patients come in with pellets, and I don't know how to help them.
So dangerous. Pellets are so dangerous. And oh my goodness, in my little local community, there's this provider who keeps advertising for pellets. It makes me want to poke my eyeballs out because they are not safe. And what the first thing you do when someone comes to you with pellets is draw levels, draw a testosterone level, serum, a free testosterone level and an estradiol level, because chances are they will be supra physiologic, and that you have to wait until those levels come down. And often they'll have bleeding because their estrogen levels are so high, and those providers say, oh yeah, go see your gynecologist about that. You know, they don't even manage their complications. It's really bad. So please don't use pellets. Yeah.
Great, thank you for the clarity.
Sorry, my daughter always says, you know, Mom, it's a good thing people pay you for your opinions. You have a lot of opinions.
Could you comment, particularly as we think about increased risk for venous thromboembolism, whether smoking is a contraindication or relative contraindication to hormone therapy?
That's a great question. Wow. You know, I think that it could be. I mean, I have to say, I have one patient who has a history of a provoked clot, and I have her on hormones. She's an MD, and she's like, I know the risk that I'm taking. I want it. So it's really about risk benefit. I think you're a little bit in no data land there. And I think you just have to document and explain why you did what you did. I mean, obviously smoking, if she can quit smoking, that's the number one thing she's going to do to impact her health the rest of her life. And if she's not there and she's miserable, people who smoke have worse hot flushes. So you might try a really, really low dose and with just a lot of reevaluation and frequent visits. Mm-hmm.
Great. Well, many thanks, Dr. Adams. I do want to respect that we're right at the 9 o'clock hour, and so we'll wrap up questions for today. Certainly some remain, and we'll continue to look toward your resources provided. Thank you.
Thank you. And here's my emails. And please, you know, I like I said, the people in my group at OHSU and I will come talk to one fellow if you want us to talk to. You know, we feel like for the rest of our careers, it's educating other providers. So thank you so much for having me, and please reach out if you need advice. All right. Thanks. Mm-hmm.